medicine in the mega online course. Please allow me to extend a warm welcome to all of you. In fact, a warm welcome cannot be complete without warm words. It's with great pleasure we welcome all of you in this session. This session is actually a very unique and special one. It will focus on the intensive care medicine from 3 of our lecturers today who are experts in the field of intensive care medicine. Our first lecturer is going to be Dr. Yasser Zaghloul, and there is no words we can convey our respect for Dr. Zaghloul. We would like to, however, take this opportunity to tell Dr. Zaghloul that it's our honor and pleasure to have him here today in this session. Dr. Zaghloul is an anesthesia and intensive care medicine consultant who is working in Sheikh Khalifa Medical Center in Abu Dhabi in United Arab Emirates. Dr. Zaghloul is a director of the Abu Dhabi Anesthesia Club, and he has presented more than 200 lectures in national and international anesthesia courses. Dr. Zaghloul was graduated from Faculty of Medicine in 1986 in Alexandria. Luckily, it is my same college where I was graduated from. He was trained in Egypt and he was trained in Ireland as well, and luckily I am from the same area as well. So Dr. Zaghloul is a fellow of College of Anaesthetists of Ireland, and he holds as well many other degrees in the field of the intensive care medicine. Today he's going to present damage control resuscitation. I'm going to leave the mic now for Dr. Zaghloul. Very welcome.
Okay, thank you, Dr. Ramona. Because of the time, we have to start with already 5 minutes. I lost it. Anyway, we will talk, as you see, about the damage control resuscitation. So first of all, what is damage control resuscitation does mean? Actually, there is some crisis coming ahead and you have to control this damage. First time this term of damage control is used, how to control the capacity of the ship to absorb the damage. You can see there is a significant damage of the ship, but it should do its job. So this is the damage control means. Now, when I am talking about these lectures, I have 2 main sources. The European guidelines, which is published in Critical Care Journal in 2019, and the Advanced Trauma Life Support student version, which is published by the American College of Surgeons Committee of the Trauma, and this published 2 years ago. So this is the main 2 sources of my lectures. And of course, there is another references, you will find it in the lectures. First of all, when you have patient with severe trauma or peri-trauma or polytrauma cases, you should have some pre-hospital care. Pre-hospital care, as usual, ABCDE approach as in all critically ill patients, but we will focus in some patient pre-hospital care. Can I intubate the patient? Can I give him tranexamic acid? Which fluids I can give? Can I use blood or blood products or no? So each point I will discuss it very shortly. Regarding the pre-hospital intubation, they found that it doubles the time of transfer, more air complications, and higher incidence hypoxia, hypo, and hyperventilation. So it looks increasing the mortality or morbidity. If it is necessary and you have a skilled person, you should optimize the first attempt and the same standards as you are going to intubate in the hospital. And from the trauma audit research in UK, they found that the mortality in pre-hospital intubation is higher, 33.7% in comparison to the patient who came without intubation, 28.3%. So in short, pre-hospital intubation may increase the mortality and you should optimize the condition before intubation. The second point regarding the tranexamic acid. When we compare the 30 days mortality of the tranexamic acid, you can see the survival rate is higher in the tranexamic acid group, especially in the second day. After 30 days, it is almost together non-tranexamic acid group and tranexamic acid group. So you can give tranexamic acid before hospital transfer. The third point, can I give IV fluids before transferring the patient? It may be a logic practice, but it found that it may be harmful in some patients. And if you use hypertonic solution like hypertonic saline, it will worsen the coagulopathy because it may induce some acidosis. So IV fluid, despite it is logic to give it, but it may not be harmful and it is not routinely recommended now in all patients. The third point regarding the blood transfusion and the blood products, there is no significant changes regarding the trauma-induced coagulopathy, ICU or hospital stay or mortality. So it looks in the 4 point for pre-hospital transfer, you can give tranexamic acid, no need for intubation, no need for IV fluids, no need for blood-to-blood products. Now the patient come to the hospital, you will follow the same approach again, ABCDE approach, and you have to work in trauma team. Actually, trauma team is very complicated in trauma patient. You can see emergency room, personnel, surgeon, anesthesia, radiology department, lab, blood bank persons, ICU, nurses, technicians, social services, and operating room. So you may have more than 10 or 15 persons working with the trauma patient. In polytrauma patients, that means you are going to do damage control resuscitation. So what is the difference between the resuscitation and the surgery? We will see now. This is the component of damage control resuscitation. First, the airway ventilation, hemodynamics, which include IV fluid, blood, and vasoactive medications. You have to use hemostatic resuscitations, give FFP, platelet, tranexamic acid, factor 7. If indicated, you have to normalize the metabolic changes in the patient and organ protection to avoid secondary brain injury, especially with patients with traumatic brain injury, and you give analgesia sedation. And in center of that, the damage control surgery. So this is the component of the damage control resuscitation. You are carrying all the body and the patient may need damage control surgery. This is the stages of surgery, damage control surgery. Before hospital transfer, the patient severely traumatized, you have identified and to inform the hospital which patient who may need surgery. After that, the patient coming for ER, from ER to operating room, just minimal intervention to control the damage, control the bleeding or soft tissue damage. After that, the patient go for ICU for 1 or 2 days for full system support, ventilation, hemodynamic, coagulation, renal, caring of the traumatic brain injury, all this aspect working in ICU. Then after 1 or 2 days, the patient may come to the operating room again to do definite surgery. And lastly, after a few days, the formal closures. We have here when the indications of damage control surgery. If the patient comes with deep hemorrhagic shock, has severe bleeding and coagulopathy, this is the patient targeted for damage control. And the other factors, hypothermia, acidosis, accessible major anatomic injury like the posterior surface of the liver, the patient need for time-consuming procedures, the total metabolic changes, the patient is not able to have long surgery, 3-4 hours, and major injury outside the abdomen, usually in patient with traumatic brain injury or chest trauma. So this is the decision to take for damage control surgery with your surgeons. We have some examples for damage control. Abdominal trauma, the patient may have opened the abdomen, as you see, closure will be done later on. Patient has external fixation. You can see the patient here and femur fractures. It is not possible to fix all in one sitting. So just put the external fixator and he can come later for internal fixation. Patient with severe traumatic brain injury and refractory brain edema for medical therapy, he may need decompressive craniectomy. And lastly, the patient with vascular surgery, it is difficult to do definite anastomosis, so temporary shunt, and he can do full shunt later on. Now, intra-hospital care, as we mentioned, ABCDE, you have to follow the basic trauma life support regarding the primary survey, secondary survey, tertiary survey. And after that, you have to start with the airway and the ventilation. We have a lot of challenges in patient with trauma patient. Patient may have full stomach, so high risk for vomiting. spine, you need manual inline stabilization. Patient respiratory compromise, either central depression or the patient has severe chest trauma. Even he will not benefit from the pre-oxygenation. Urgency, you may don't have the skilled person or the equipment is not enough. Head injury, you have to avoid increase in intracranial pressure, hypoxemia, hypercarbia. Any medication you will give to help you for intubation may cause significant hypotension and abnormal anatomy. Patient has maxillofacial trauma, it may be difficult to intubate. Any other comorbidities. So airway is very challenging in trauma patient because a lot of factors. One of our patients, this very simply may be eye injury, difficult to do mask ventilation. In this patient, he has mandibular, mainly maxillofacial trauma. There is no head trauma, that's why he has nasal intubation. So this patient may be difficult to intubate and difficult to put the laryngoscope. Another patient fall from height and he has, you can see, maxillofacial trauma, soft tissues coming from the mouth, and she has a stable C6 and C7 fractures, and this patient is intubated with gyroscope. May have more severe trauma, like this one, full of heavy objects in the face and the chest, and you can cut wound in the face. This is the left eye. And this patient extremely difficult to do routine laryngoscopy, so he needed urgent cricothyroidectomy, and after that it was changed to the permanent tracheostomy. And you can see the surgical emphysema because of the patient has pneumothorax from the trauma. Anyway, it is very challenging airway in trauma patients. Other problems, the patient may have cervical spine injury, and you have to do manual inline stabilization. Ultimately, you may have 4 persons doing that. The persons who is going to do the tube, you can see 2 hands in doing the manual inline stabilization, the person who is giving the medication, and there is 1 person doing the cricoid pressure at the same time. Also, it may be 3 persons only. You can see the manual inline stabilization, giving good space for the person who is going to put the tube, or you can do manual inline stabilization just to opposite the patient. No need to fix it from behind here. Now, any patient after intubation need ventilation. So the routine lung protective ventilation, low tidal volume and moderate PEEP. Lung ventilations mean 5 points. The lowest FiO2 to avoid the effect of hyperoxia, low tidal volume to minimize the effect of volume trauma, low plateau pressure to avoid barotrauma, application of PEEP to avoid athletical trauma or to protect against atelectasis, later on in ICU to avoid use of muscle relaxant and to use the assist cellular mode. So this is the lung protective ventilation in all patients, including trauma patients. PEEP in trauma, you have to balance between low or no PEEP in patient with high ICP or hemodynamic instability. He may need higher PEEP in case of lung contusion. Patient may develop non-cardiogenic pulmonary edema, like patient with severe traumatic brain injury, transfusion-related acute lung injury, or aspiration. So you have to balance between low and high PEEP and to take your decision. Generally, you have to optimize the oxygen delivery. You have some factors who may reduce the oxygen delivery, like anemia, bleeding, hypovolemia, hypoxemia, heart failure. So you can correct this by blood transfusion, more oxygen, fluids, and you may need to give inotropes. Also, there is some factors which may increase the oxygen consumption. You have to minimize it, like pain, agitation, shivering, you have to control. So factors which may increase oxygen delivery and factors which may reduce oxygen consumption. Organ protection, it is very common in trauma to have traumatic brain injury, and you have here 12 factors which may cause secondary brain injury. All start with H except seizure start with S. So 11H plus 1S. Hypotension, hypoxemia, this is the most common, most important. And you have to differentiate between hypotension and hypovolemia. There is, in trauma patient, other causes of hypotension. We will mention it very soon. Hypercarbia, hyperthermia, acidosis, anemia, high ICP, hyponatremia, hypoglycemia, hyperemia due to the reperfusion injury and seizure. So you have to prevent the secondary brain injury. patient with crash injury may have rhabdomyolysis and release of myoglobin in the circulation, which may precipitate in the renal tubules, causing acute renal failure. So this patient should have good hydration. You should give mannitol, and you need to do acidification of the urine by giving sodium bicarbonate. So organ protection, we focused on the brain and on the kidney in the same time. Now we come to the hemodynamics and our current recommendation from the European guidelines to maintain the systolic blood pressure between 80 to 90, either giving by IV fluid or you may need vasopressor as well. In patients with traumatic brain injury, you need the MAP, not the systolic blood pressure. The MAP around 80, especially in patients with severe TBI, to avoid secondary brain injury. Now, we have some classification of shock according to the volume of the blood lost, class 1 to class 4. Class 1, loss of 750, 2, loss up to 1.5 liter, 3, up to 2 liter, and class 4, more than 2 liters. And you have 1, 2, 3, 4, 5, 6 clinical parameters, so you have to follow it. The interested point in class 2, for example, here, the patient may have loss of 1.5 liters and all the other signs is very close to the normal, except the mild tachycardia. So the current recommendation, don't wait for hypotension, because hypotension may be misleading. You have to depend on the history, physical examination, marker of inadequate perfusion, decreased venous oxygen saturation, increased lactate, perfusion-related low pH. This acidosis not related to the other. Suppose the patient has renal failure, so he will be acidotic. So the acidosis is not related to some other pathology and base deficits. So this is the parameters you have to adjust it. Don't wait for hypotension. Serum lactate actually is very sensitive to measure and estimate the monitor and extent of bleeding of shock. And our target is lactate clearance. Actually, this is not new. Since more than about 27 years, this study found that the survival rate according to the lactate clearance. If you are able to clear the lactate within 24 hours, the survival rate may be up to 100%. If the lactate takes 2 days, the survival rate is around 75% only. If the lactate is high for 2 days, so the survival rate is around 12% only. IV fluid and blood resuscitation. So which fluids, colloid or crystalloid, which crystalloid, low or high volume, this permissive hypotension, what is your end point of resuscitation? Everyone is aware about that. There is no good option to use colloids in trauma patients. Crystalloids are our main fluids during resuscitation. So there is a lot of talk about that, to use starch, gelatin, or something like that, but it may increase the complication. So in short, we have to use crystalloid. But which crystalloid, ringer lactate or normal saline? Everybody is aware also about the metabolic acidosis or hyperchloremic metabolic acidosis, which may occur with the normal saline. When you are resuscitating the patient with normal saline in trauma patients, the patient is already acidotic. So after that, you give normal saline, more acidosis. You all may be overreact. You may consider this acidosis from hypoperfusion, hypotension by the trauma. No, actually it is by normal saline that you give. So ringer lactate should be given as primary solutions. Maybe in patients with traumatic brain injury, normal saline is better. So hyperchloremic metabolic acidosis is not a benign self-limiting metabolic disturbance. It increases the mortality, may cause renal dysfunctions, and increase the length of hospital stay. So another issue, permissive or liberal fluid strategy. You find that restrictive fluid strategies or subpermissive hypotension is better in trauma patients, and especially in penetrating trauma patients, which is stab wound or gunshot. It is better to use restrictive fluid strategy. In blunt trauma is not clear. It is maybe different from patient to patient according to the clinical situations. Low volume resuscitation may be contraindicated in patients with spinal injury, traumatic brain injury, patients with hypertension, or elderly patients. But remember that low volume doesn't mean delayed resuscitation. You may push initially half liter, 1 liter, then you have to assess your patient. You will keep him a little bit hypotensive or restrictive fluid therapy. Another important issue, you are giving fluid, you are giving vasopressor. What is your end point? This is, as you see, most of this issue, clinically, you can assess it very easily. I didn't mention any device. Blood pressure around 65, higher in TPI, patient saturation more than 95, the lowest PEEP, lowest FiO2, urine output around 0.5, hemoglobin around 9, and the lactate clearance, especially within the first 6 hours or within 24 hours. So these 5 parameters during the end point of resuscitation. Can I use vasopressors in trauma? Yes, but it is not studied well. If you are going to use it, respect the recommended objectives. You need the systolic blood pressure around 80 to 90. If the systolic blood pressure 80 to 90 without vasopressors, you have to stop it. This is, I mentioned earlier, also you should consider the non-hemorrhagic causes in hypotension. Patient with chest trauma may have cardiac contusion, hemopericardium, tension, pneumothorax. He is not hypovolemic. Spinal cord trauma may cause spinal shock. Patient with severe TPI, Glasgow Coma Scale 8 or less, he may have what is named neurogenic stunned myocardium. The massive release of the adrenaline and noradrenaline increase the afterload too much. The patient will have dilated cardiomyopathy. Blood transfusion, because it is damage control, you need massive amount of blood. So what is your target? What do you think? How much hemoglobin we need during damage control resuscitation? Our current recommendation 7 to 9, but do you think 7 is enough? I will give you some explanation now. This is German guidelines in multiple trauma patient, German Trauma Society. What they told us, if patient has active bleeding during acute resuscitation, you should keep the hemoglobin around 10 or hematocrit around 30. So 7 is not enough during acute resuscitation. I am not talking about the patient who is on ICU after a week, after 10 days. So this is different categories of patient. I am talking now about the acute resuscitation. So target hemoglobin should be more than 9. And during acute resuscitation, blood transfusion not only restores the intravascular volume, oxygen delivery, but also it reverses and improves coagulopathy, acidosis, hypothermia. So you can understand intravascular volume and oxygen delivery, how hemoglobin or RBCs can correct coagulopathy or can correct acidosis or can correct hypothermia. Everybody is aware about the buffer system of the body. 3 main items: bicarbonate, plasma protein, especially albumin, and hemoglobin. Hemoglobin is responsible about 25% of the buffering capacity of the system or of the body. So if your patient is acidotic, it is not possible to give bicarbonate only 7 point, pH less than 7.1. Usually with severe bleeding, the albumin is low. With severe bleeding, hemoglobin is low. So which system will cause the buffering system? That's why I always stress in good hemoglobin 9 or 10 during acute resuscitation, not only for the intravascular volume, but for the buffering capacity of the hemoglobin. Another issue, the patient is hypothermic. You are doing your best to warm your patient, but still he's hypothermic. There is a lot of reasons. Exposure, cold fluids, impaired shivering, loss of heat regulation, spinal cord resections, but we have important metabolic failure due to the hypotension, hypoxemia, and anemia. So if you correct this reversible factor, hypotension, hypoxemia, and anemia, it will help to normalize the patient temperature. So hemoglobin should be more than 9 during acute resuscitation. Regarding the effect on coagulopathy, I will explain it very soon. If you are going to resuscitate your patient, should be very early and aggressive, and you should remember the lethal triad: acidosis, hypothermia, coagulopathy, all cause bloody vicious cycle. Again, I always change it to lethal quad. I add low hemoglobin, especially in the presence of hypocalcemia. So it is lethal quad, not triad. Anemia is lethal like acidosis, like hypothermia, like coagulopathy. So I think everybody's asking, is RBCs important for hemostasis? What do you think? Yes or no? Yes, of course. It is responsible to sustain normal hemoglobin. That's why Allah subhanahu wa ta'ala created us with hemoglobin 30 or more. Resuscitation is important for activation of for platelet and thrombin generation and activation of the elastase by activated factor 9. So all this is important for coagulation system. The other issue also, if you see fibrin here, fibrin needs RBCs and the platelets. If there is no platelets, no RBCs, how the clot will be formed? So it will cause negative impact on the platelet activations. So again, in short, hemoglobin should be around 9 to 10. Hypocalcemia is important as well, and you have to correct it because it may increase the mortality. Lethal quad, not lethal triad, especially in hypocalcemia. Now the last point in the lecture, the blood products, how you give it. FFP, platelet, cryofibrinogen. The current recommendation, FFP should be given FPT, EPTT more than 1.5. But you are now in OR, ER, or ICU, and there is no time to check. What you should do with the first unit of blood, you should give 4 units of FFP. This is everybody's aware about 1-to-1 ratio for transfusion. For platelet, should be more than 50,000 or 10,000 in traumatic brain injury. Again, no time to check it, transfuse it with the 6 or 8 units of the blood. Because if you are given 6 or 8 units of blood, that means the patient lost more than 50% of his blood volume. So sure, 100% the platelet is low. Maybe the platelet function is normal, but it may be very low, not enough for good hemostasis. Fibrinogen or cryoprecipitation is more specific. You have to check fibrinogen level before giving cryo or fibrinogen. Now we have 2 medications may help you for hemostasis. Tranexamic acid, since 10 years we have the very common crash 2 injury, and they found considerable reduction in the risk of death in trauma patients. So it is routine now, all trauma patients to have tranexamic acid. And it should be given 1 gram over 10 minutes, followed by 1 gram over 8 hours, and it should be early as soon as possible, within 3 hours of injury. And the first dose, it is better to give it pre-hospital, as we explained earlier in the start of this lecture. Because the success of the tranexamic acid in trauma patient, is used in acute traumatic brain injury crash 3 trial, and they found that it is safe in patients with TBI and reduces the head injury related death. So patient with traumatic brain injury, you can use tranexamic acid as well, the same protocol like trauma patients. The last point in my lectures, the activated factor 7, which is a little bit expensive drug, but if you have it, you can use it according to some special precautions. Now, the patient has massive bleeding, blunt trauma, not penetrating trauma. And you did everything. You gave RBCs, surgery is done, embolization was done, bleeding stopped, khalas, nothing can be done after that. Persistent bleeding, you have to consider factor 7. But hematocrit should be around 24, platelet more than 50,000, fibrinogen more than 1, pH 7.2 or more. And the dose recommended 90 mic per kg. If the bleeding is stopped, nothing is needed. If persistent bleeding, you can give the second dose within 1 hour. Is it not possible in acute resuscitation to check all this? So if the patient needed up to 10 units of blood and ongoing microvascular bleeding, just oozing, not macrovascular. If the bleeding can be stopped, surgeons, this is something else. But microvascular bleeding, and you already give 8 to 10 units of blood, you can consider factor 7. Now, in conclusion, this is the components of the damage control resuscitations: airway, hemodynamic, hemostatic resuscitation, metabolic hemostasis, organ protection, analgesia and sedation, and in focus of that, the damage control surgery. And when you are working in teams, there is no I in team. You are working with all the persons around you. And thank you very much for your attention.
Dr. Amona, for you.
Yeah, Dr. Zaghloul, thank you so much for the fantastic presentation. I cannot tell you how many people has contacted me telling how they are impressed by this presentation. Thank you so much. I have few questions for you. And the first one is from Dr. Anhar. She is asking about the why low volume resuscitation is contraindicated in the old age group, please.
Okay, we have the questions here. What is the tranexamic acid doses? Are using only bolus or IV? I think I answered that.
Yes,
You have to give.
Yeah, that's why I didn't say that question. So can you please tell us why low volume resuscitation is contraindicated in an old age group?
Sorry, I didn't hear.
So Dr. Anhar is asking why low volume resuscitation is contraindicated in the old age group.
No, this is not contraindicated. The hypotensive or the restrictive fluid therapy maybe it is to be not considered in old age, because old age need usually high perfusion, and the perfusion, for example, for most of the vital organs, the curve shift to the right. He may need higher, like hypertensive patient. So it is not contraindicated. Just to be conservative, especially hypertensive patient and old elderly patient. Could be conservative for restrictive permissive hypotension. But in TBI, spinal injury, you have to maybe absolute contraindication to avoid secondary neuronal injury.
Perfect. Thank you so much. The next question is coming from Dr. Asma, and she's asking, what is better, tranexamic acid or fibrinogen, in your opinion?
Tranexamic acid, actually, when I talked about crash 2 is done more than 20,000 patients in around 40 countries. So it is proved this. There is to have good evidence to use tranexamic acid. And as mentioned, it should be given within 3 hours. First dose 1 gram over 10 minutes. Second dose 1 gram given over 8 hours. Only 2 doses, because there is some incidence of thrombosis and other side effect. In most of the patient, of trauma patient, higher incidence of DVT and pulmonary embolism. Is patient receiving tranexamic acid, you should watch for the signs or symptoms of DVT or PE after giving it.
Perfect, perfect. Thank you so much. We have so many questions, but I will just take one more to allow other speakers to start. The last question today is from Dr. Hatem, and he's asking, does steroids, corticosteroids, have any role in resuscitation in trauma patients?
No, there is no. It is not. Actually, I didn't read about the corticosteroids in resuscitation. I have no idea about that. Maybe if somebody else have. According to my reading, according to the main 2 sources I mentioned, there is no mention for corticosteroids.
Perfect, perfect. Okay, so thank you so much, Dr. Zaghloul. I'm going now to move to the second.
Just I will mention the questions which is written. I will answer it by now. I will write the answer now. Okay,
yeah,
so no problem here.
Yeah, okay, perfect. Thank you so much. I think we are now running out of time. There are so many questions in the panel, and there is huge interest from all audience about the arrhythmia. Myself personally, I find arrhythmia one of the most difficult and challenging, things to treat and to read the ECG. So thank you so much for this excellent presentation. I would like to thank all the speakers for today. Dr. Samir Al-Ansari, thank you so much.
Thank you very much.
Dr. Zaghloul, thank you so much. Your presentation was more than excellent. We really enjoyed the polytrauma patient, and I think you will have a homework for tonight. Multiple questions in the Q&A, and please answer these questions if possible. And Dr. Adel Hussein, thank you so much. Dr. Saad Mahdi, many thanks for your effort.
Thank you.
Our audience, thank you so much for attendance today. It was great attendance. We hope to see you again in the next session in our online anesthesia mega course, and have a very good night for all of you. Bye-bye.
Thank you. Thank you very much.
Bye.
Thank you.
Bye-bye.
Thank you. Thank you.
Yeah, okay, perfect. Thank you so much. I think we are now running out of time. There are so many questions in the panel, and there is huge interest from all audience about the arrhythmia. myself personally, I find arrhythmia one of the most difficult and challenging, things to treat and to read the ECG. So thank you so much for this excellent presentation. I would like to thank all the speakers for today. Dr. Samir Al-Ansari, thank you so much.
Thank you. Thank you very much.
Dr. Zaghloul, thank you so much. Your presentation was more than excellent. We really enjoyed the polytrauma patient, and I think you will have a homework for tonight. Multiple questions in the Q&A, and please answer these questions if possible. And Dr. Adel Hussein, thank you so much. Dr. Saad Mahdi, many thanks for your effort.
Thank you.
Our audience, thank you so much for attendance today. It was great attendance. We hope to see you again in the next session in our online anesthesia mega course, and have a very good night for all of you. Bye-bye.
Thank you. Thank you very much.
Bye.
Thank you.
Bye-bye.
Thank you. Thank you.